Welcome, everyone, to Exploring the World of Headaches. We have Dr. Yanis here with her today, and she is going to be sharing with you her knowledge about how we can understand the triggers, the cause, the effects, and all of the treatments. And I will turn it over to you.
Right. Thank you so much. Hi, everyone. Just a quick introduction. Thank you so much for explaining what we're doing today. I'm here at Morton Plant North Bay. I did my training at University of South Florida, and I ended up doing an additional year, something called clinical neurophysiology, which isn't on headaches, but we have such a strong headache program at USF that it was pretty much part of our training. So I'm very, very passionate about treating headaches, specifically migraines. And so I'm happy to give out some information, and hopefully if anybody on the call is a migraine sufferer or a headache sufferer, give you some information to help better equip you for treatment and management going forward. All right, so why is this important? Headaches are a very, very common neurologic condition. I'd say it's probably, if it's not 50%, I would say at least 30% of the patients I see are for some type of headache on a regular basis. We're going to be talking about this, not only figuring out what the causes of different types of headaches are, what are the potential triggers specifically for migraineurs, and then the old and new treatment options available to treat them. And the goal of this talk is to empower you as the listener to better manage headache symptoms if you are a sufferer or if a loved one of yours is a sufferer. So some of the common types of headaches that we see. The ones that people who don't suffer from migraines typically complain of are tension headaches. So those feel like a band, and it would be just kind of around the forehead, temples, around your head. It feels like a vice almost. That's a very common type of headache that we encounter, usually worse with stress, lack of sleep, things like that. Migraines are another very common type of headache. Like I said, about at least 30 to 50% of my patients that I see suffer from migraines. Those symptoms are a little different than tension headaches, but sometimes they go hand in hand. So the most common symptoms that we see with migraines are severe throbbing, one side of the head or both sides of the head, and they are often associated with other neurologic symptoms. So some people will experience blurry or zigzags or like a prism in their eyes with headaches. Oftentimes, nausea is a very common side effect with migraines and occasionally vomiting, but there are a multitude of other complaints that people have when it comes to migraines. And they're very vague and broad. So that even includes brain fog, dizziness, feeling difficulty moving, and there's many triggers for migraine. So every person is different, every brain is different, so it just depends on what what happens during the migraine that can categorize it as a migraine. Cluster headaches are a bit different. Those are often associated with they're cyclical, which means that you can go for a very long time without any sort of headache, and then suddenly you have a headache multiple times a day, every day for days, weeks, even up to a couple months. And they often are associated with very severe eye pain. So the way that migraines are, it's usually one whole side of the head. Clusters are different. They usually involve one of the eyes. And they're often also involved with tearing, redness, or even weird symptoms like sweating on that side of the head, like inappropriate sweating or lack of sweating. And so those are very severe. And the population that experiences cluster headaches is a little different than migraines, but anybody can suffer from those. The treatments are also different. So just going to see a neurologist to get the right diagnosis, to get you on the right treatment, is always the best option if you suffer from headaches. Sinus headaches are very common. I usually rely on my colleagues in ear, nose, and throat, or an otolaryngologist to help with treating sinus headaches, but those are typically along the cheeks and the forehead. A lot of pressure, usually worse around allergy season, or if you've ever suffered from chronic ear infections, chronic sinus infections, those are often associated with that pressure type of headache. And cervicogenic headaches, those are often another very common type of headaches that I encounter. So they typically are in people who have neck pain. So neck pain from car accidents, from different things that can cause neck injuries or chronic neck pain can often lead to pain that goes up to the back of the head. And there are a few different types of headaches that fall under that category. But that's another common type of headache that I encounter that are not migraines. So what causes migraines? We still don't have a 100% clear answer as to exactly what is the migraine pathophysiology, but we do have a lot of research that understands at least some of the different things that are involved with having migraine syndromes. So the first step is having some sort of triggering event. So triggers I kind of alluded to earlier are very common with migraines, and I'm going to go through a whole list of them later on in this presentation. But the first part of a migraine is a triggering event, something that exacerbates pain, and you'll start in one part of the brain, but it'll lead to spreading into different areas along that side of the head, but also can spread to the other side of the head. So cortical spreading depression. So that's the first stage of a migraine. And so something in one part of the brain is triggered by a pain receptor or some sort of event that can provoke pain, and it spreads to the other side of the head or along the entire side of that head. This activates the trigeminal nerve. Now, the trigeminal nerve, you have two of them. They supply the sensation on the side of your face. So if you think of your face kind of like a letter E, that's the distribution of the trigeminal nerve. And so that's often where people's headache pain is worse, is around the eye, around the forehead, and the temple. And that's supplied by the trigeminal nerve. When the nerve is activated, this releases signals in your brain called neuropeptides. And there are several of them, but the one that's most important, and I'll talk about it later in the presentation, is the CGRP neuropeptide, or the calcitonin gene related peptide. The reason that it's important is because it's it's integral in a pain process with migraines, and so now we have newer medications that can target this specific receptor that is only involved in migraine and severe nerve pains of the face. Neurogenic inflammation. So with all of those neuropeptide release, what it does is that it makes all of the vessels in the supplying your brain dilated. So it opens it up. It sends more blood to those areas, those nerves, and the receptors that respond to nerve pain. And it also increases inflammation. And so that is part of the migraine cycle that continues that pain after the initial triggering event. That also is why people describe migraines as throbbing. So the actual vessels opening and the inflammation is what causes that throbbing pain. This leads to pain perception in the brainstem and thalamus. So brainstem and thalamus, those are important areas in the brain that help for us to interpret and feel pain. And pain is not good, but it is good in order to tell your body something is wrong. And so those are the areas of the brain that are involved in pain. And it's interesting because the actual brain tissue itself, so your brain doesn't have pain receptors. So if you went to have a neurosurgery, you don't feel what happens when your brain is when surgery is happening on the brain. It's really the coating of the brain. So the meninges, there's 3 layers that cover the brain. That's where pain actually is felt whenever you're having headaches. And so all of these are happening, along the cortex, so the most superficial part of your brain, but that is where people feel pain. That's why if anyone has ever had meningitis, and that's an infection and inflammation of the meninges, the parts that cover your brain, that's very painful. But the actual brain itself, it's involved in all the processing, but that's not where the pain is. It's all along the surface of the brain. With this, pain begets pain. So I always tell my patients who suffer from migraines, the more headache pain you have, the worse that cycle becomes. So the more frequent your body gets stuck in that pain cycle, it's very simple for a very small trigger to cause a very severe pain. So by cutting off the cycle is how I try really aggressively to prevent migraines from occurring. Because if you don't, they can last. The classic migraine is at least 4 hours, so it can last 4 hours up to days, and that's a lot of patients who have ever suffered from a very severe migraine lasting multiple days that cannot be treated at home end up in the hospital. So the goal is always to figure out if, one, you have migraines, two, if you're in chronic pain or you have many days in the month where you're suffering from migraines. How do we, one, treat your migraine and prevent them from coming back? Because the better treated they are, the less likely you are to go into that pain cycle. The other part of a migraine, after you've gone through that cycle and it's stopped, you have what's called the post-drome phase, which can, after the pain has gone away, you can still have lingering symptoms. So fatigue, difficulty concentrating, or brain fog. And then even you might have milder pain, but it's not as severe as the migraine. That all can happen for hours, days, or even up to a week with migraine syndrome. Common causes and triggers. So stress and anxiety is a really, really big one. So making sure you check in with your stress levels, figuring out ways of preventing yourself from getting overwhelmed from life stressors, because life is stressful, is really important in helping facilitate treating migraines. So I'm a big proponent in making sure you check in with yourself, because that's one of the biggest triggers. That unfortunately life is stressful. It's unavoidable to have stress because we're alive. And so making sure you not only reduce the stressors that you can avoid, but also figuring out how to manage the stress that builds up in your body from just being a human being. Hormonal changes are another big trigger. So oftentimes migraines start in young, healthy women. That's a very common population of patients that start having migraines. And so those hormonal changes as we're growing and developing, that's where very big proportion of patients who start having migraines that develops. Sometimes things get better after the hormone changes resolve, but those are a very big trigger for a lot of patients that are either starting to have migraines or getting worse migraines later in life for whatever particular reason. Dietary factors. So if you've ever suffered from a migraine, or if you know someone who suffers from one, oftentimes they'll know what their triggers are. The most common culprits are caffeine, chocolate, red wine. Those are the big ones that oftentimes, if you've ever had a migraine, you probably have heard those are the most common triggers. But there is a multitude of other ones, and I have a slide that goes through a few of those. Environmental factors. So oftentimes patients who suffer from migraines will say, I need to sit in a cold, dark room because bright lights, strong smells, or loud noises make my headaches worse. And so those are a very common trigger that can make a headache get worse or keep you in that headache phase for longer. And sleep disturbances or regular schedules are also a very common trigger. We don't, as in America in general, our society, we don't value the benefits of sleep. It's more, we are very trained on working hard and getting as much done in all the hours that you're awake. But sleep is so important. It's restorative. It helps to metabolize all of those toxins that build up in your body on a regular basis. So people who don't sleep well, who get chronic insomnia, or have work night shifts, or are up very, very early and go to bed really late. So if you only are able to sleep less than 7 hours a night, that's a really big common cause of migraine triggers. And so it's important to reassess what your sleep looks like, because that's a very simple thing that doesn't require medications that can help. Okay, so some of the common food triggers, I mentioned a couple. So ripened cheeses are a very common trigger. Chocolates, nuts and nut butter, so that includes peanut butter. Excessive amounts in certain foods. So MSGs can also be a trigger. And this is an all-inclusive list. It doesn't mean that everyone who has migraines is triggered by this, but I like to talk about it because let's say you just introduce something into your diet, or you say, every time I have dark chocolate right before I go to bed, I always have a migraine when I wake up. That's something simple that can be modified, that can help not only to reduce how severe your headaches are, but also hopefully prevent them from coming back. Along that vein, smoked meats, artificial sweeteners, specifically aspartame, can also cause migraines, and alcohol in excess. Specific types of alcohols are more likely. So red wines, there's certain liqueurs that I have an all-inclusive list that I give my patients to be mindful of, but those are things to be aware of. Some of the other things that are not as common, but potentially can be causing your migraines to get worse, or let's say you're on a really good medication treatment and you're still having migraines. This is when I tell people, let's go back to the drawing board. Let's figure out what could be causing your headaches so that you know that, let's say, if you want to enjoy your specific food, just be aware that your migraine might get a little bit worse. So vinegars, except for white vinegar, fermented, pickled, or marinated foods, yogurts and sour cream can also cause it. And then specifically the yeast, so hot, fresh bread, raised coffee cake, and donuts. Basically anything that's delicious can cause migraines. Just be aware of that. And then the pods of certain beans and pea pods can also cause migraines. Onions, basically acidic foods can also cause migraines. So citrus and let's say the tomato sauce and pizza. Bananas are a very surprising one. And the reason why I added to this list, not only it's a known trigger, but I like to mention an anecdote for one of my patients. She suffered from migraines her whole life, and then she went on vacation to a tropical place. She mentioned that she was having a migraine every single day, and we figured out that she had eaten a banana every single morning that time. And then after she got back from her vacation, she wasn't eating bananas anymore. Her headaches went back to her normal frequency. And so we usually say no more than half a banana a day if that is your known trigger. And then caffeine in excess. And that doesn't just include coffee, but caffeinated teas, energy drinks, a lot of new supplements to help for energy have a certain amount of caffeine. And that's also including chocolate. Chocolate, especially dark chocolate, has caffeine. So it's important to be mindful of the different sources of caffeine you drink on a daily basis. Sodas too. So making sure you don't drink more than 3 caffeinated drinks per day. So I try to really stress the importance of treatments that are not medications. So I already mentioned before, keeping a regular sleep schedule, trying to get at least 7 hours per night is a good long-term goal. Stress reduction, so doing different things that are good for your body, good for your brain. Those include yoga, meditation, and if needed, I refer patients to cognitive behavioral therapy for additional supportive services. Staying hydrated and making sure you adjust your diet to help prevent triggers. And like I mentioned before, not everybody has the food triggers that I listed. And there are triggers that are not foods, but that's something that you have to figure out for yourself what it is that's causing your headaches. But I usually encourage patients to at least make one change. So let's say if you do drink a glass or a glass or two of red wine every night, but you're having every day, you're having a migraine, maybe just cut back for a week, see if your headaches get it all better. If they don't, then you can go back to your normal life. Or if there is anything that you've been eating more frequently, be aware of that. And this will lead me to one of my other recommendations, which I put it later on, is keeping a migraine diary is very, very important. It helps to not only figure out what your triggers are, how frequently they're happening, but also if you start a medication, your doctor needs to know if your headaches are getting better. And it's sometimes hard to quantify. So by actually writing it down on your phone or I have an app called, an app that I recommend called Migraine Buddy. By knowing, quantifying how many actual headache days you have per month gives us an idea of what's working, what's not working, and how we can figure it out. Exercise and physical therapy are important, especially for the cervicogenic headaches. So if you have neck pain and those are making your headaches worse, it's important to take care of your neck, and physical therapy is sometimes a good option for that, and avoiding your definite known triggers. So what do we give for patients with migraines? So a lot of you probably are familiar with some of the medications on this list. So acutely, so if somebody never has a migraine and has their first time a migraine, it's safe to try an NSAID unless there's a reason why you can't. And that includes Tylenol, Excedrin, ibuprofen, and naproxen. And all that Excedrin is Tylenol, caffeine, and aspirin. And so some people, part of their headache treatment is to take caffeine, and we often give it in the hospital if it really necessitates it. So it's just knowing what works for your body and what doesn't. And if it's just you don't get frequent headaches, taking over-the-counter medications is generally a good idea, but taking too many can actually cause more complications. Triptans are a very, very old class of headache medications. So if you've ever heard of sumatriptan, zolmitriptan, elatriptan, there's a bunch. So if it ends in triptan, that is an old medication that we've used for migraines for many, many years. It works well in a lot of people, but there are some downsides. So if you have cardiac issues, if you have high blood pressure, I really try to avoid starting you on it or trying to take you off of it if you've been on it for a long time. And it doesn't work unless you start it at the very beginning of a migraine. So if you wait 4 hours in, the likelihood that your headache's going to respond is very low. So that's the other downside of triptans, but they are inexpensive. They've been around for a long time. We know what the risks and benefits are. And so that is still a medication that's used very frequently for stopping a headache. Another one, Furoset, kind of falls within the NSAIDs, but that's another prescription medication for treating acute migraines. Anti-nausea medications, For the most part, nausea medications are very good with helping with migraines. Nausea is a very common feature of migraines. There are a couple that can make migraines worse. So it's just about, does it work for you? Does it help? Or if it doesn't, then you try a different one. And then the newer class of medications, the CGRP receptor antagonists, are the cleanest, best medications that are now commercially available for a lot of patients. The most common names, Nurtec is a one that a lot of people know. It's the Lady Gaga medication, some of my patients call it, if you've seen the commercial with her. And then Ubrelvy is a similar type of medication. These are medications that you would take by mouth. They usually dissolve, and they're helpful not only at the start of a migraine, but well into a migraine cycle. Some of the other treatments that I also like to talk about are some supplements. So for preventing headaches, there is some evidence that a few different supplements can help, and so those are the top three on this list. Magnesium oxide. The only thing I tell people is that magnesium is used as a stool softener. So if you develop soft stools or diarrhea, that probably could be from the magnesium. So that's the only thing I tell people. Just be careful when starting. But otherwise, you have magnesium in your diet, in your body, so it's generally well tolerated. The dosing I usually recommend is about 400 milligrams daily, but everyone's different. So if you need a lower dose or higher dose, it's just what your body responds to. Vitamin B2 is another good supplement to help migraines. It's called riboflavin. And so usually tell people around 100 milligrams per day. And coenzyme Q10 or CoQ10, 300 milligrams daily. These are all available over the counter on Amazon, wherever you get your vitamins, but these are all good starting points for someone who's suffering from regular migraines that doesn't have any reason why they can't be on any of the supplements. The older classes of medications that we use for prevention were beta blockers, so propranolol, esmolol, anything that ends in olol, which is normally to help lower your heart rate, and it's also used as blood pressure medications. They do have a role with helping prevent migraines. And so it's a really good medication for someone who has high blood pressure and also suffers from migraines. That's a good starting place or irregular heart rhythms where they go very high. Those are good medication to kill two birds with one stone. Anti-epileptics. So these medications, even though the class of them is for different things, when these were included in clinical trials, the patients that suffered from migraines found that their headaches got better on them. And so even though it's not the first reason why these medications exist, we do know that they do help with migraines. And that's also why we understand that migraines are not straightforward. There's a lot of different things that contribute to migraine pain. So the CGRP is one known neuropeptide that is involved in migraines, but we know that there's a lot more to it that we just don't have all the pieces of the puzzle. And so that's why we know that these medications work for some reason, but we can't tell you exactly why, not yet at least. Anti-epileptics calm the electric stimulation of your brain, and so that is what's part of that cortical spreading. That's the part that it's helping with. And so Depakote or valproic acid and lamotrigine or Lamictal are very good medications to help prevent migraines, and especially in certain populations. So in young healthy women who plan on having children, Depakote is a terrible option, but lamotrigine is a safe one. It's been tested in populations of women who are pregnant or can become pregnant, so that's an option for people who also suffer migraines. And then antidepressants are a really good option for migraines as well, especially if you suffer from depression and there's a medication that could help with your migraines. Amitriptyline is one of the oldest ones that can help, but there are others that also have a role. And like I mentioned, the CGRP class of medications, there's different forms of it. There's the monoclonal antibodies. So there's some that actually bind to the CGRP receptors in your brain, and it helps modify how many are there, because the more pain you have, the more your body produces. But by trying to target those receptors and take them away, you have fewer pain receptors. So when your pain signals shoot up, you don't get as big of a response. And so they come in medication form by mouth, they come in injection form, and they come once a month injections, every 3 months. And then there's even for really, really bad migraine sufferers, there's infusion therapies that happen every 3 to 6 months. So I've talked about a lot of this since it's kind of a lot of minutia, but essentially it's just a very clean class of medications. And I didn't put it in my slide, but another great migraine prevention that I offer it, my colleague and I offer it in our clinic, is Botox for migraine. So botulinum toxin, we understand that it plays a role in relaxing the muscles in our body. And at very, very low concentrations, we use it for a lot of different reasons. And my colleague and I, we both trained, like I said, at USF, we did clinical neurophysiology. So we use it for pretty much all of the different indications for a neurologic case. So migraines, um, blepharospasms. There's a lot of different things, spasticity, dystonias. We have a lot of different reasons why we use it, but it's an excellent medication for, especially for patients that can't take medications by mouth or have failed one or two different other headache medications and are still suffering from regular migraines. Okay, so yeah, the CGRP, like I mentioned, they're new, they're cleaner, they work better. We know it's involved in migraine pain, so that's why it works really, really well. And it typically has fewer side effects than the older classes of medications. I usually tell patients about 2% of people on these medications will have worsening nausea, and about 2% will have some sort of like allergic reaction. So if you're allergic to medications, just be aware that potentially you can have an allergy to it, but it's usually the things that are like the preservatives, the other parts of the medication. So for the most part, they're really well tolerated. So I usually recommend, if you have to start something and your insurance covers it, start with the cleanest medication that's available. And I already mentioned some of the pros. Um, they're good for patients who, for instance, who have been suffering from migraines for a very, very long time. You've been on old medications. They might work well, but they're not 100%. This is a good decision to switch over if you've suffered from migraines for a long time, or you cannot be on triptans anymore. So, like I mentioned, very high blood pressures, or if you have coronary artery disease, I usually say you shouldn't be on a triptan because those can increase your risk for complications. It's nice because you can use it as an as needed or as a prevention. So there's some that you take once a day, and then there's some that you only take when you have a really severe migraine, and they're well tolerated with few side effects. The cons of these medications, the cost is very expensive. So I usually tell people there's a sticker shock if you go to the pharmacy and you don't use your insurance and you don't use any of the coupon savings cards, or if you're not enrolled in the financial savings program. But with commercial insurance, these are really well covered. And so I usually tell people, just put your information, your insurance information, into the savings card. That'll help cover the cost for a whole year, and you just reapply every year if it doesn't fall over or roll over. The long-term safety is still under study. So these medications are a newer class. So within my training at USF, they were only starting to be commercially available pretty much at the end of my training. So it's a new medication. For the most part, all of the data is very promising, but we don't have 20, 30, 40 years like we do for the other medications. So that's something to be aware of as well. And it's not, the one other downside is that it's not all effective in all types of headaches. So there is an indication for cluster migraines with one of the specific medications in this class, but not all tension headaches need prevention, and other types of headaches. And I didn't go through all the other types of headaches. There's a whole umbrella of migraine or headache types called trigeminal autonomic cephalgias, and those include trigeminal neuralgia and a bunch of other things. And cluster headaches are under that window, but not all headaches respond to these. So it's unfortunate, but it's if you are have if you're able to try it and you have migraines, it is worth a shot to be on the cleanest medication. When to seek help. So for patients who develop new headaches later in life, that's a reason to start, either get a scan with your primary doctor or see a neurologist. It's not normal to get headaches later in life. So if you suffered from migraines your whole life and they've never changed and they're better now, that doesn't need treatment. But if something new or something else changes, it's important to seek medical attention. Headaches that are sudden to severe, if they're very sudden and very severe and you've never had a headache before, or they're different than your typicals, that's an emergency. It's important to go to the ER if you're having severe, worst headache of your life, because there are other things that cause headaches, such as brain bleeds. So it's important to get that checked out. New headache type of pattern. So type or pattern. So let's say you've always had migraines your whole life and suddenly you're having different types of headaches. Those are things that might need a little bit more investigation, especially if you haven't had a new scan in a while. Headaches with fever, stiff neck, confusion, or seizures, those are all medical emergencies. So that's something you should not be waiting on. Headaches after head trauma. So headaches after head injuries are very common. A lot of that's usually the most lingering symptom that occurs after head trauma. So if you had head trauma and you're continuing to suffer from headaches, it's important to seek medical attention. And then frequent or worsening migraines. So you've always had migraines, but suddenly they're happening almost on a daily basis or over 15 times per month. You should be on some sort of treatment, and so that's important to seek medical attention for that. And if it's been going on for many months, that doesn't have to be an emergency. That can just be a regular follow up with a neurologist. So some summaries and tips. So hopefully through this brief introduction to headaches, you at least have an idea of what the different types of headaches are, how why headaches occur, especially migraines. We have plenty of new medication treatments, so your job is not to remember everything, but know that there are plenty of options available, and try to figure out a way to empower yourself to have fewer headaches, or at least if there's a loved one in your life, figure out a way to have fewer headaches on a regular basis. I mentioned the migrainebuddy.com. It's a really good app that it's free. You can use it to track your headache symptoms and see if there's patterns, triggers, anything like that. It's important to, there's no magic pill. So it's important to still focus on lifestyle modifications alongside if you do need medication management, but really lifestyle changes are a big part of what I strongly encourage when I see my patients. And then speak to your primary care provider first. A lot of primary care providers are very comfortable treating with run-of-the-mill migraines, especially if they're not happening frequently. And if you're still having a lot of headaches and the normal baseline medications aren't working, seek care with a neurologist for further assistance. And consistency is the key to long-term relief. So it's important that whatever works, you got to keep doing it, and whatever doesn't work, you got to let that go. So being consistent is really important to help treating chronic migraines and other types of headaches. All right, that's all I have. Thank you for your attention.
Wow, that was a lot of information. And as I've been reading through the chat, my heart goes out to so many people because we all
Oh,
have
I know.
some similar paths. Those people who suffer migraines, it is not an
Mm-hmm.
easy path, and a lot of times what works for one person does not work for the other. I know some other people. Barometric pressure is my number one trigger. I
Oh, yeah.
I can tell
Mm-hmm.
you automatically when it's going to
Yeah.
rain, bright
So,
lights, smells.
yeah. I have a patient that he has the family has like a barometric pressure like reader, like if they have an actual device at home, and the patient will tell the family, oh yeah, I'm about to have a migraine, and they know it. So you can't, unfortunately, try not to live in Seattle. There's certain things like try to avoid areas that it's going to be constantly raining, but that is an unfortunate other trigger. And I didn't thank you for bringing that up because it's a very common one that we don't talk about as much, but absolutely just knowing that you can hopefully equip yourself to treat it before you're about to have a migraine or before it gets too severe, but that's a type of trigger that you can't control your environment, so you know
There are some earplugs that my neurologist told me about called
oh,
WeatherX.
I
Unfortunately,
love
they
that.
did not help me, but
Oh,
the phone would tell me when it was coming, and it was kind of funny like that. I could tell the phone when it was going to be,
yeah.
but some
Mhm.
other things occur there. There are so many things, and there's a lot of people with supplement questions, and you gave us a great list. I will send a follow-up to this presentation with a PDF of the slides so all of you can see what the triggers are. This has been recorded, and you can come back and watch it again. It does take about 3 weeks to get on the site. So in about 3 weeks, it'll be on the site, which if you look at the email I send you, it is on the bottom, the main link there. I guess one of the questions that I did see, because most of it was just kind of talking about all the stuff they have or insurance issues, and that depends
Mhm.
on each individual insurance,
Yes.
is when is it time to go to the hospital? Yes, I know when I need to go to the doctor, but when would you say, you know what, if you're seeing this, you need to be going to the hospital?
Yeah. So those I'm going to go back to that slide that I mentioned before. So when you have sudden severe headaches that are different than your classic migraine. So if you've always had the same type of severe migraine pain and nothing has changed, you don't necessarily need to go to the hospital. But if you have we call it a thunderclap headache. So it feels like a thunderclap, the worst headache of your life. People will pass out from how severe the pain is. That is an emergency. You can't wait on that. So those are the types of headaches that I strongly encourage. If you've ever had a headache like that, going to the hospital to get a scan of your brain, make sure that you don't need additional treatment or evaluation. Those are life-threatening types of headaches. Headaches with fever, stiff neck, confusion, or seizures. Those are that what I worry about with that when I hear those things is infection of the meninges or encephalitis. So meningitis or encephalitis can present with a headache, but if you have fevers, you can't bend your chin all the way down to your chest, you're acting odd, or you have a seizure. If you never had a seizure in your life, go to the hospital. That's not something you could sit on, okay? So that would need an evaluation for an infection of the brain or spinal cord. And so that kind of headache is not your classic run-of-the-mill tension headaches, migraines, or the other ones I mentioned. If you have an acute head injury and if you've hit your head hard enough that you either passed out or you're not back to normal, you should go to the hospital. Like that, these are the things that everybody should do. It's not just what I'm telling you now, but this is a more common sense things. If you pass out or you're very confused or you're having a severe headache with fever, those are things that need to be evaluated in the hospital because they can treat you with antibiotics, they can get scans, they can do a lumbar puncture. Those are things that will not be fixed over the phone. And then for things that are new onset headaches later in life, and then worsening migraines or a new type of headache, but you've always suffered from headaches, those are the things that you should seek. That's not an emergency necessarily, but you should talk to either your main doctor, get a referral to neurology, or at least your main doctor can get a scan of your brain just to make sure that everything looks okay. That helps us to at least get a baseline of what your brain looks like and make sure there isn't anything structurally that's causing it. But those are the emergencies are really these three. But if you're having a headache or a severe migraine that's not going away, no matter what you try at home, that's a very common reason why people come to the hospital. We can give you IV medications, especially if you're nauseous or vomiting. If you need, we call it a headache cocktail. So it's a combination of different medications that work well for migraines. You can go to the ER. Oftentimes after one, patients feel well enough to go home. But that if you're having severe headaches like that and you're not taking a medication to help prevent you from having migraines, that might be a good starting point to either talking to your main doctor or finding a neurologist who can help you with that.
Could you speak a little bit on the correlation between migraine sufferers and stroke probability?
That's a good question. So untreated migraines can increase your risk for vascular complications in your brain. One of the most common MRI findings that when I order an MRI on a person who suffers from migraines, the most common thing you might see on the report or your neurologist might mention is there are non-specific chronic microvascular ischemic changes. So I like to tell people that these are silent changes. There are many things that can cause it, but migraines are a very common thing that, especially in a young, healthy person or someone who doesn't have high blood pressure, high cholesterol, diabetes, or smokes, that's a very common thing that we see on the brain that doesn't necessarily cause a stroke, but it does tell us that you might be at risk. Your risk for strokes are slightly higher than a person that doesn't suffer from migraines. In general, migraines alone are typically not enough to increase your risk for a stroke, but it does bump your risk up slightly. So I highly encourage patients that are chronic migraine sufferers. At that point, you should be on a treatment because if you only get one migraine every year or two, that's probably not enough that's not enough to start a preventative medication. But if you're suffering from 4 or more migraines per month or 15 or more headache days per month, that's something that warrants treatment. And so chronic over 10, 20, 30 years of your life, that does cause those small microvascular changes in the vessels of your brain. And so those are things that it's important to get on a medication to help prevent that from progressing, to reduce your risk for strokes and other vascular events.
That's awesome. I do know I teach the American Heart Association, and there was one of the things I used to show as this newscaster was on TV, and she started slurring and
Oh,
speaking nonsense. And it ended up she was having a complicated migraine. They thought
oh,
it might have been a stroke, but it was actually a migraine
yes.
that she was having. And I know reading the chat, there are some of us who have a little
Yeah.
aphasia at times when you
Yeah.
have that headache. But a question that came through, and I think this is important, is, and I know for myself, they had a hard time diagnosing me because they thought I had cluster headaches. Then they thought I
Yeah.
had this because I
I
have very
know.
weird headaches,
Hmm.
of all the different symptoms. And I think reading this, a lot of people do too. You
Yeah.
know, it's not important that you name it necessarily. It's important that you get to a doctor and they can treat what specific
Yeah.
symptoms you have, correct?
Exactly. Absolutely. And that's why, and there's overlap. A lot of headache patients have multiple different types of headaches. So my patients with sinus headaches and tension headaches and migraine headaches, I say, okay, we're going to try to aggressively treat one type. And if those get better, then maybe your tension headaches are better because you're less stressed out about having a headache all the time and you're sleeping better because you're not suffering from a migraine. So if we can treat one, the other one gets better, and you're still having a different kind of headache cause that may not be responding to the medications, we go back to the drawing board and figure out what those could be. But that's why you see a neurologist. That's what I do, day in and day out. But there are so many great neurologists that treat this, and it's just finding the right one that can diagnose you with the correct one. Because you're right, it's hard because there's some headache types and headache syndromes that are not easy to diagnose, and so we that's what we do. But I'm glad that you mentioned the complicated migraines. So aphasia can be associated with a migraine aura. That's a type of symptom. But like you said, if you have stroke-like symptoms, you need to go to the hospital. If you've had this or your family has complicated migraines and you've been evaluated and you are not having a stroke, we treat your headaches aggressively. And if they never happen again, then we have our answer. But stroke-like symptoms you should be going to the hospital. And if let's say everything looks normal and you're having a headache and your symptoms go away, then that's the our answer. But you shouldn't um, hope that it's a complicated migraine and it's actually a stroke. So it's important to seek medical attention if that occurs.
Again, as I teach CPR a lot and stroke awareness, and one of the things I teach is you can't die of embarrassment. So
Yeah,
if you are unsure, always dial 911. Let someone who knows what's
absolutely,
going on check and make sure, and that way it can get you to that next step. One of the
absolutely.
things that is mentioned a lot is a lot of people with different headaches, dehydration is an issue, but
Yeah,
sometimes people just drink water, and sometimes that can just put you into hyponatremia, especially if they're guzzling tons and tons of
yeah.
water. What are your thoughts about that?
Yeah, I like to tell patients, especially like if you are very athletic and you're out, running marathons or you're constantly doing something that causes you to sweat. When you sweat, you're losing salt and you need to replenish that salt. So I try to tell people to alternate. So water is great. It's 0 calories, but if you are doing something that's physically exertional, you should supplement with electrolyte drinks and don't overdo it. You can drink in moderation. You don't need to drink 2 or 3 gallons of water a day. But using electrolyte drinks, I usually recommend you have to have a little sugar in them. So the ones that are 0 sugar, you need the sugar and to get the salt into your cells. So I just try to say like the low sugar options. So like Pedialyte, it doesn't taste as good as Gatorade, but it has less sugar, and that's helping to supplement your the salt that you're losing. But the IV hydration, there's a lot of really good options. So I just say whatever you like that tastes good, just making sure you're drinking plenty of water on a regular basis, but don't drink, like you said, don't drink only water and you end up in hyponatremic state and that causes a bunch of other complications.
Yeah, I know. I dilute it with coconut water. Sometimes I'll do an
Yeah,
electrolyte drink with coconut water just to kind of do
perfect.
that better. Do you have
Absolutely.
any data or any thoughts on are headaches hereditary?
Yes. So I usually jokingly, but oftentimes if there is a family member who suffers from migraines, it's more likely for other family members to suffer. And so I always tell people you get your good looks, your good manners, and your migraines from your mom. So oftentimes if your mother suffers from migraines, and it's not just moms, but oftentimes migraines, I see a lot more patients with who are females who have migraines than males, and there's a lot of reasons for that, but um, the if you have a family member who suffers from migraines, there is some sort of genetic predisposition. It doesn't mean that you're definitely going to get them, but it can increase your risk.
All right, just looking to see again. A lot of people are chatting amongst themselves about the different types of migraines they have. I had no one in my family who had headaches, so it was kind of
Yeah,
shocking when I started going with it is. So yes, it is, but you never know.
yeah.
We
Mhm.
are at time. I want to
Okay,
thank everyone for being here, and thank you especially because I do think this is um, a topic that so many people suffer with, and possibly maybe we can bring you back another time to go into another path of headaches and neurological information. But
absolutely. Yeah, my pleasure.
we do have more talks coming up this year. There's a couple of people talking about allergies. We do have someone coming in talking about allergies actually later this year, and I know that they can contribute to headaches. Also, that was kind of on your list too. But I want to thank everyone for being here. This has been recorded. We will be putting it up. It does take our digital team a couple of weeks to get it going, so I always like to say 3 weeks, and if it gets there earlier, yay.